Okay. So this is Ann Schwemm. She's from the University of Washington. She's a pharmacist. And she's going to tell you a little bit about her specialty and what she's done in the past. And then we'll have tonight's presentation.
Okay. Thank you very much. And thank you, everyone, for taking time out of your day. I know it's nice and warm and sunny outside. So hopefully over this next hour, everyone will learn a little bit about, a little something about monoclonal antibodies. My background, I am currently an oncology pharmacist based at the University of Washington. I work primarily at the Seattle Cancer Care Alliance. In my area, or my clinic areas are primarily breast cancer. I also do a little bit in our GU clinics, but I primarily work in our breast clinic. I did my training at the University of Michigan. And originally went to school and got my public health degree and my pharmacy degree at the University of Iowa. So I ventured out west after my training, and I love the Pacific Northwest. It's a great place, and I've really have loved my time in Washington. So we can get started. If at any time you have questions, please don't hesitate to let me know. I'm happy to take questions at the end or throughout or whatever is convenient for you. I have nothing to disclose. Maybe someday I will, but currently I do not. Our objectives today will be a lot of the focus of today's presentation is going to be on the mechanisms of action in pharmacology, which of course, as a pharmacist, is something that I really love, of monoclonal antibodies. We'll also look at some unique toxicities and some common toxicities that we see with this class of drug, and talk a little bit about the management strategies that are used. So just a brief overview of what we'll talk about in the next hour. I will give a very high-level view of the development of monoclonal antibodies, and my apologies up front for anyone who played any part or has been involved in that study, because it's very complex and took decades of work, and I will do it in just one slide. We'll also talk about the mechanism of monoclonal antibodies as a class, and then also provide some explanation about the nomenclature. Monoclonal antibodies are a mouthful with their naming, and lots of oohs and mavs and all these things that go in, but there is some rhyme or reason to the naming, and that can help you understand how what these drugs are targeting, what they're derived from, and some of the risks that you may see when you use these medications. We'll talk about management of adverse drug reactions or side effects that we see, and spend a little bit of time on infusion-related immune reactions, because they are the major class side effect of monoclonal antibodies. And then the bulk of the talk is going to be about new monoclonal antibodies. And so we're going to take about the last 12, or the ones that have been approved in the last 5 years, and go into some detail on those, focusing on the unique mechanisms and novel mechanisms of action. A lot of first-in-class within the monoclonal antibodies have come out in the last 5 years, and hopefully I can explain to you their mechanisms, and we'll also review some of the landmark studies that got those drugs approved to the market. So again, from a very high-level view of looking about the development of monoclonal antibodies. So monoclonal antibodies can be produced in large quantities for therapeutic uses against a very specific target. And they are a clone of one specific antibody, monoclonal. And the development utilizes the property, actually, of multiple myeloma cells. And these myeloma cells are malignant B cells that can proliferate indefinitely in cultures. And they are monoclonal in nature and secrete immunoglobulin. By fusing myeloma cells with normal B cells, you yield these hybridomas, or this hybrid of cell lines. And so the very rudimentary explanation of how these molecules are made is that they immunize a mouse with a protein that they're designing, so protein X. And they remove the mouse's spleen cells and fuse these to create hybridomas with myeloma cells. These cells then undergo a selection technique that picks out certain cells, and they use an assay to basically screen surviving cells that are secreting an antibody against the X, which you initially immunize the mouse against, and then you have that single entity antibody that you can then clone and create this large quantity of this therapeutic monoclonal antibody that you want to target specifically for. So, therapeutic monoclonal antibodies are among the fastest growing therapeutic classes. They have been developed in a broad range of indications, primarily oncology, also infectious disease, autoimmune diseases such as RA. You may see many commercials or direct consumer advertising for RA, also cardiovascular disease, including hypercholesterolemia. They create a novel opportunities for treatment, and that the human diseases that they are being developed for have a high target specificity. They also do not undergo renal or hepatic metabolism, which is very nice because in patients with renal or hepatic dysfunction, you don't have to worry about dose adjustments or altering the medication. They're also dosed less frequently, albeit by generally parenteral administration. Some are also approved by the subcutaneous route. So we're optimizing the long half-life that monoclonal antibodies in general have, generally of about 3 weeks. So our patients only need to come in and get a dose every 3 to 4 weeks rather than taking something on a daily basis. From the safety perspective, monoclonal antibodies today are being engineered to reduce the risk of target-related and modality-related adverse events. When they were first developed, monoclonal antibodies were mouse-derived, as described in the previous slide, and the technology has continued to grow in that they went from mouse to chimeric to humanized to now fully human monoclonal antibodies. So the mechanism of action in general of monoclonal antibodies can be divided into 2 categories. The first being direct. And this is really the very pure, what you would think of as an antibody mechanism of action, which the antibody binding to the antigen and therefore blocking that interaction with whatever ligand it's targeting. So whether it be a cell surface receptor, a membrane-bound protein, growth factors and different things, and then resulting in cell modulation. Most monoclonal antibodies, as antibodies in general, use the variable region of our antibody structure to produce the direct effect on targeted biology. The kind of neat side of the mechanism of monoclonal antibodies in my mind is the indirect. So antibodies targeting a cell stimulate the recruitment of all the effector cells just like our immune system does, with the capacity for antibody-dependent cellular toxicity and phagocytosis. And it also can create complement-dependent cytotoxicity. So the antibody binding to that target cell results in activation of the complement cascade. Recently, within the last couple years, the technology has come out to be able to conjugate things to these monoclonal antibodies. So not only can you have a very specific target in your treatment modality, but then you can attach a medication, a different toxin, a radioisotope to that monoclonal antibody to have an extremely targeted way to treat disease. We'll talk about 2 of these today, antibody drug conjugates, that are the first ones that have come to market. I previously mentioned a few of the uses and indications that monoclonal antibodies are used for, primarily malignancies, but also in some of the first monoclonal antibodies developed in the late 1990s were for transplant rejection. Also, a large class of these antibodies are used for autoimmune disease, such as rheumatoid arthritis or lupus, and also including infectious disease and cardiology. So moving on to naming. So there's kind of a lot going on in this slide, but hopefully I can direct you. So in the name of the monoclonal antibody, I'm actually going to lead you to one of them that we're going to be talking about today, which is belimumab. And there are different sections of every monoclonal antibody, and they all end in mab, which is nice to tell you that these are monoclonal antibodies. The letters directly in front of the mab also tell you a lot about where the antibody is derived from. So whether it's a murine, chimeric, or mixed, humanized, which is about 90% human, 10% mouse, and then fully human monoclonal antibodies. This directly correlates with the potential for immunogenicity. So murine, or if you have rituximab being infused or something, you know you have a higher risk of reaction just because of the name and not necessarily knowing exactly what the monoclonal antibody does. So the mouthful that you sometimes get with these names do have an intent. The letters right before that are directing you to the disease or the target that this monoclonal antibody is for. There's a lot of these. These are just some examples, and belimumab is a human monoclonal antibody that is targeting the immune system, or LIM, for the treatment of lupus. So the naming does have a rhyme or reason, and it tells you a lot about it. There's a variety of these and what they're targeting. A lot of the tumor-based ones are TU, so trastuzumab, pertuzumab, have that target. So it really tells you a lot about the drug just from the name. These medications are primarily given through the intravenous route, although there are some that are approved for subcutaneous administration. And these have many advantages, including very quick administration of the systemic delivery of the drug, complete bioavailability, and ability to deliver higher volumes of the medication. Although this comes with a few disadvantages. Although it's only given every 3 to 4 weeks, it does require a patient to come in frequently when it's given intravenously to an infusion center, which can be inconveniencing to the patient. It's also, these medications are extremely costly. It's an unfortunate situation, and there are lots of patient assistance programs and things that are out there that I always encourage working with my providers and our patients to look at this, because there are a lot of programs out there that need to be utilized and should be utilized by all patients. An infusion reaction. So because these drugs are given intravenously, and just purely based on the mechanism of infusing an antibody into your system, infusion reactions are quite common. And because of this, the subcutaneous and intramuscular routes of delivery continue to be studied for agents where it's not already an option. So we're going to spend the next few slides talking a little bit about the mechanism of the infusion-related reaction. So it's not completely understood, but there are a couple of proposed mechanisms by which this occurs. And the primary one is purely the antibody-antigen interaction that results in a cytokine release during the administration. So a good example of this is rituximab, and it is a drug that targets the antigen of CD20 on circulating cells, and it is followed by a release of cytokines from the lymphocytes. And they've been able to, one of the neat things about CD20 and rituximab is that you can measure a patient's disease volume. So you can measure that CD20 count. Patients that have a higher CD20 count have worse infusion-related reactions than patients that have a low CD20 count. Same concept as when you're giving a first infusion versus second, third, fourth, fifth infusion, your disease burden is much higher on dose 1. So often you are getting a greater effect of that antibody to that target that you are targeting. Often your levels of the target diminish as you continue on therapy, so the rate of infusion should be less. There's also thought to be an ability for us to elicit this human anti-chimeric, anti-human, or anti-mouse antibodies to the actual monoclonal antibody. And this is a little bit more debated, as they've only been able to capture these antibodies in about 1% of patients that are getting the infusions, and the infusion-related reactions is much more common than that. But this could also be a contributing factor. So patients present with infusion-related reactions in a variety of ways. Often the very typical fevers, chills, flushing. I hear a lot of chest pain, and my heart is racing, hypertension, even hypotension, eyes watering, nose watering, palm sweating, which is a more mild to moderate presentation. You can also see the extreme of acute anaphylaxis. Patients will have and experiencing cytokine release syndrome. It generally occurs within the first 30 minutes to 2 hours of the infusion. although it can occur within the first 24 hours. So we always tell people to be very aware, even after they go home or are driving back to wherever they're from when they're getting their infusions, that this is something to keep an eye out for during the first 24 hours after your infusion. Risk factors are correlated with the high disease burden, as we kind of discussed. The higher target that you have floating around in your body and you're giving this very specific targeted therapy to, the higher chance of risk of infusion-related reactions. And then also just first exposure. About 80% happen on the first dose, and about 20% occur after that. So what can you do? Medications that have a known high risk for infusion-related reactions, generally pre-treatment with antihistamines, acetaminophen, and glucocorticosteroids, and really monitoring the patient. So we also do a lot with titrating the rate. And so almost all of our monoclonal antibodies, you will see a longer infusion time for their first visit, and then you can shorten that time based on how the patients are tolerating it. I've heard from our nurses, they say they appreciate, to say, I have to titrate this medication every 15 to 30 minutes because it facilitates their staffing. And so they're able to say, I need to be at the bedside every 15 minutes to titrate this, and so I need to be near this patient during the whole time. And so that helps facilitate an eye on that patient during the time that they're getting the medication. But it is very important that they're monitored very closely. So treatment. Definitely stopping the infusion. A few times I've gotten a phone call where the infusions are still running. So stopping the infusion is very important in providing symptom management for patients. Often we are redosing again with an antihistamine or diphenhydramine and giving hydrocortisone. Sometimes if they're having shortness of breath or severe anaphylaxis, might require epinephrine. So generally we do re-challenge these patients. We slow the rate down quite a bit, generally a quarter or half rate, and we'll restart it with these pre-medications, obviously depending on the risk and benefit of giving this medication to the patient based on their disease. Severe anaphylaxis is generally not, re-challenge is not recommended, although successful desensitization has been demonstrated with some of our monoclonal antibodies that are out there. Trastuzumab is a huge antibody used in breast cancer, and there has been some studies that have shown even patients that react, which that reaction rate is quite low, that you can desensitize the patient to the medication. A few other kind of class side effects. Infections is a big one, so we're usually modulating the immune system in some way, shape, or form with these agents. So looking at vaccines that are recommended or required before starting therapy, or prophylactic antibiotics that might be necessary. We can see some platelet or thrombotic disorders. Commonly we see actually autoimmune diseases. On the oncology side of things, we're often ramping up the immune system, where on the autoimmune side of things, we're often diminishing our immune system. So we see a lot of aggravation or simulating autoimmune diseases when we're using these monoclonal antibodies for an oncology indication. Also, dermatitis can be a concern, specifically with endothelial-targeted monoclonal antibodies. Sometimes they can result in quite severe, almost acneiform rash that can occur patient's face, scalp, upper trunk, things like that. So there are a lot of things to be aware of and provide some specific management for that. Secondary malignancies, or malignancies if you're treating a non-cancer diagnosis, can also be seen. And cardiotoxicity is a big one of our HER2-directed monoclonal antibodies. So this is as most complete list as I could come up with, and I hope I haven't missed any. It was much harder than I thought to try to find all the monoclonal antibodies that have been approved. Adalimumab is our first fully human monoclonal antibody that was approved in 2002. All the ones on the left are oncology indications. All the ones on the right are everything else. And this chart compiles the monoclonal antibodies that have been approved in the last 5 years. And so this is what I'm going to try to speed through and talk to you about. These new antibodies that have been developed. We're skipping a couple that are pretty rare, Castleman's disease, CLL. We're going to try to hit up the rest of them and focus on their mechanisms and the data that brought them to market. So just based on their disease, we'll talk about melanoma and the 3 drugs that have been approved recently for that disease: ulcerative colitis and Crohn's, gastric cancer, breast cancer, Hodgkin's lymphoma, lupus, and osteoporosis. So we'll start with nivolumab, pembrolizumab, and ipilimumab. And as a group, these drugs are considered checkpoint inhibitor immunotherapy. And ipilimumab is targeted at the anti-cytotoxic T lymphocyte antigen 4, or I will refer to it as CTLA4 antibody. And nivolumab and pembrolizumab are targeted at the anti-programmed cell death 1. I'm really glad they decided to name that PD-1 antibody, because I don't think many patients would want to take those. So to talk a little bit about the mechanism by which they work, I'm going to step back a little bit and just talk about the activation of cellular immunity. So the activation of cellular immunity is dependent upon our T cells being able to identify peptide fragments that are presented by our antigen-presenting cells on a nice little platter with our MHC molecules. And this interaction requires a co-stimulatory factor of the interaction between CD28 and B7 on the antigen-presenting cells. This then is our on switch for the activation of our cellular immunity. When the CD28 and B7 bind, we have an upregulation of our CTLA4 cells on our T cells. And these CTLA4 then competes with CD28 to bind to B7. When CTLA4 binds to B7, it creates the brakes on the immune system. So ipilimumab was developed as a fully human IgG1 monoclonal antibody. And as I was just showing on the past slide, the CTLA4 is a downregulator, or the brakes, on T cell activation pathways. And ipilimumab basically cuts those brakes. So it blocks that CTLA4, therefore not allowing CTLA4 to inhibit the CD28 and B7 interaction. So it allows for enhanced T cell activation and proliferation. So CTLA4 is the brakes. Ipilimumab comes in and blocks that receptor, basically cuts the brakes and revs up the immune system and keeps it going. In melanoma specifically, ipilimumab may indirectly mediate some T cell mediated anti-tumor response as well. And it has an indication for the treatment of unresectable or metastatic melanoma. This was based off of basically 2 phase 3 trials. The first one was placebo-controlled and looked at previously treated patients with metastatic melanoma and showed an overall survival difference of about 3.5 months compared to patients getting placebo treatment. And a randomized controlled phase 3 trial, which looked at untreated metastatic melanoma patients with advanced disease, compared them to dacarbazine, which is a standard chemotherapy used for the treatment of metastatic melanoma, compared to dacarbazine plus ipilimumab. And it showed about a 2-month improvement in overall survival, and it also showed maintained efficacy, which is a 5-year overall survival of 18%. I've also shown here a combined analysis, a meta-analysis that was just published a couple months ago that looked at all the patients that have received ipilimumab. And if you don't know a lot about metastatic melanoma, until about the last few years when these drugs have come out, it really had about an overall survival of about a year. And you would go through all lines of therapy and have a very dismal outcome. So these drugs that have come to market have really changed that even with one line of therapy, you're almost getting to your year overall survival. The very neat thing about this drug is patients have a durable response. And so in the studies, they found that the magical dose was 3 mg per kg every 3 weeks, and you get 4 doses. And you go, which is not the general situation when you're treating cancer. You continue to give treatment over and over and over, as patients progress. You give the 4 doses, and patients that have responded have a durable response. And that is considered if at least 3 months after they complete therapy, they've maintained a response, it's considered a durable response. If their disease starts to come back or have evidence of metastatic melanoma again, as long as they had that durable response, it is indicated to continue giving 12-week or 4 dose intervals of this medication. The other therapies that we were targeting was the programmed death cell 1, and this occurs in a fairly similar way. So we have our activated T cell, and PD-1 is present in activated T cells to kind of act in the same way as our CTLA-4. So it is a negative feedback and a brake on our immune system. So the programmed death 1 receptor binds to the programmed death ligand 1, which is present on tumor cells and antigen-presenting cells, and that basically prevents the immune system from continuing to go. So it limits the amount of immune reaction that you can have. Our anti-PD-1s actually bind to the PD-1 receptors on our activated T cells and prevent this interaction from occurring, and then keep that immune response going. And so in another sense, it also kind of cuts the brakes or keeps the immune system activating on those T cells. So both nivolumab and pembrolizumab are both targeting PD-1. And they are a fully human monoclonal antibody and act as an immunomodulator that inhibits that programmed cell death 1 activity by binding to the PD-1 receptor and blocking the ability for it to bind to the programmed death cell ligand 1 and 2. The negative PD-1 receptor signaling that regulates the T cell activation and proliferation is then disrupted, and this releases the PD-1 pathway-mediated inhibition of the immune response, including an anti-tumor response in melanoma. Pembrolizumab was approved on a trial called Keynote, and Keynote was a phase 2 trial. In oncology, phase 2 trials also have a dose-finding component, so you'll often see 2 different doses being studied. And all these patients had already progressed on ipilimumab, and they demonstrated a progression-free survival of about 33% and a complete response rate of about 25% of patients. And nivolumab was studied in Checkpoint, was its study name, and it was a phase 3 trial looking at about 400 patients, also had already progressed on ipilimumab, and they received nivolumab every 2 weeks or standard of care, and they also showed an improvement in the overall response rate, still about a third of patients responding, and the duration of response has not yet been reached in the nivolumab arm, although it was 3.5 months in the standard chemotherapy arm. So that's also a very exciting option for our patients. We actually just stopped a study on Monday that we were combining those 2 drugs. We were combining ipilimumab with nivolumab and really causing upregulation of the patient's immune system. And it was actually stopped early due to some of these reasons. So these checkpoint inhibition therapies basically cause an autoimmune disease to be present in our patients. So we're attacking the tumor, but a lot of times we're also attacking self. So we see a lot of dermatitis. Enterocolitis is probably our biggest thing that we see a lot of. We admit plenty of patients for high-dose steroids. Also hepatitis, some pretty crazy ocular toxicities are pretty rare, but enterocolitis tends to be pretty common, and it's something we spend a lot of time educating our patients, because having new onset diarrhea might not be something that they would initially think is due to this therapy that they're getting every 3 weeks, and they got that drug 10 days ago, I must have eaten something. So it's something that we really spend time educating our patients and make sure that they give us a call right away. So we can start steroid therapy. We also commonly use infliximab, which is a treatment for ulcerative colitis. in these patients, and it has pretty remarkable fast-acting results, and it's kind of become a go-to for treatment of ipilimumab and nivolumab-induced enterocolitis. Ipilimumab also has a REMS program, which is a risk evaluation and mitigation strategies program that is put on by the FDA that is aimed at healthcare providers about educating patients about the risks of these immune-related adverse events. So on to ramucirumab, which is a new medication that has been approved in gastric cancer, and it is targeted at the extracellular VEGF receptor 2, or vascular endothelial growth factor. So this is another drug in the class as the same as bevacizumab or Avastin that you may have heard of. It binds, has a high affinity for binding to the VEGF receptor, and it blocks the binding of the VEGF ligand and inhibits the activation. And VEGF is instrumental in the proliferation and migration of endothelial cells. And so by having a drug that targets VEGF, you basically reduce tumor vascularity and growth. So our tumors need a blood supply and need nutrients just as much as the rest of our body does. And so by using agents like this, we can basically cut off the blood supply and prevent those tumors from getting the things that they need, and then in a sense reduce their cellular growth. This medication was approved based on 2 phase 3 trials called Rainbow and Regard for the treatment of gastric cancer. And this was added on to standard therapy with weekly paclitaxel and showed a slight improvement of about 2 months in overall survival. And it was also studied in later lines of therapy when more hospice or supportive care would be an option to see if it was a later line therapy option as well for our patients, and it did show a slight improvement in overall survival as well. Just last month, it got an approval in, I think maybe earlier this week, it got approval for colorectal cancer based on RAISE was the trial, and then REVEL in lung cancer, it was approved at the end of 2014 for use. We won't talk about those since they're secondary indications, but it's being used in other disease states as well. It's given every 2 weeks, and it has a similar toxicity profile as we see with bevacizumab, although bevacizumab is targeted at the ligand that is circulating, where ramucirumab is specifically at the extracellular target of the cell. So it's a little bit different, but we still see very similar side effect profiles. So generally with VEGF, just as we're affecting that vasculature, hypertension tends to be a big side effect that we see and tends to be a reason that we have to stop therapy or dose adjust, but treat hypertension just like we would treat any other hypertension. Also see some proteinuria. These agents affect the infrastructure of our kidneys. And we have seen a little bit more hemorrhage than we have seen with other VEGF agents, although it could be because the majority of our usage right now is in gastric cancer, which we tend to see increased hemorrhage anyway. So bendelizumab. I think this one is my favorite monoclonal antibody that I got to learn about and preparing for this presentation, because it is not for an oncology diagnosis. So it is used in Crohn's disease and ulcerative colitis, and it targets alpha-4 beta integrin. And alpha-4 beta integrin is important in movement of molecules. And this integrin binds to mucosal adjacent cell adhesion molecule 1, or MAdCAM. And MAdCAM and this integrin bind together, and it's implicated as an important contributor in chronic inflammation of Crohn's and ulcerative colitis. And I apologize for my continued elementary level artwork, but so what happens is we have T cells that are migrating through our vasculature, and we have these alpha-4 beta integrins that are hanging out on the T cells and also just floating around in our bloodstream. And these MAdCAM1 molecules are kind of on the lining of our vasculature. Once you have a MAdCAM1 bind to your integrin, they're able to slip through into the extravascular space and head to where the inflammation is. So in our ulcerative colitis or Crohn's patients, to the gut. What vedolizumab does is binds highly to integrin. So it prevents this interaction from happening, therefore keeping those T cells in your vasculature, not allowing them to slide through and get to the gut where all the T cells are aggravating the lining for our Crohn's and ulcerative colitis patients. I think that's really cool. So this drug was brought to market through a randomized controlled trial of about 400 patients that were undergoing active ulcerative colitis induction therapy. And they added on vedolizumab for 3 doses. And at the end of that 6-week period, they found an improvement in their clinical response rates, their remission rates, as well as the mucosal healing, which I think is really important. They continued this medication for either 4 or 8 weeks, or patients did not continue on it. And at the end of a year, they found their remission rates were between 40 and 45% compared to 16% in the placebo group. So they followed the dosing that was in the trial, providing this dose at every 8-week intervals in the maintenance setting, because they found no difference between that 4 and 6-week dosing. So there's no reason to give extra drug if you don't get any benefit. Another unique thing with this medication, if by this first 8-week dose or by 16 weeks from starting, if the patients aren't experiencing an improvement in symptoms, is recommended to stop therapy because they're likely not going to experience a resolution of symptoms. The side effect profile reading the trial is actually quite well tolerated. Some headaches, arthralgias were generally the most common thing seen, as well as our infections and hypersensitivity that we see in a lot of our agents. Moving on to some breast cancer, 2 big drugs got approved in breast cancer over the last few years. And these are both HER2-directed therapies. And when I'm talking about these drugs, and monoclonal antibodies, not a lot of people use them. I was trying to quantify the amount of people these drugs affect. And the only ones I was able to do it with really was these breast cancer drugs. So breast cancer affects 1 in 8 women, and about 25% of them will have the marker that these drugs need to be used in. So 1 out of 30 of your patients will probably have exposure to one of these drugs, if not both of them. So the first one I'll talk about is atotrastuzumab emtansine, a mouthful there. It was the first humanized monoclonal antibody drug conjugate. And it is basically Herceptin or trastuzumab that is bound to a small molecule chemotherapy. It's called emtansine. Emtansine has been on the research shelf for a long time, and it was too toxic, and it failed all these trials to be used alone. But when you bind it to something, a monoclonal antibody that delivers the drug very specifically to our HER2-positive tumor cells, it is able to be used. So it's bound, it's a microtubule inhibitor, and it's bound by this thioether linker to trastuzumab. Every trastuzumab molecule has 3.2 emtansine molecules attached to it. And it targets the HER2 receptor of breast cancer cells. And upon binding to that HER2 receptor, the emtansine, or the entire molecule, the atotrastuzumab emtansine, is internalized and releases the emtansine. Then the emtansine goes to work intracellularly on the microtubules. It also inhibits HER signaling downstream, which is instrumental in causing the breast cancer in our HER2 positive patients, and inhibit shedding of that HER cellular domain that is overexpressed. So the Amelia trial, one thing I do love about breast cancer trials is they're all named generally after women. Supposedly they're all named after women in history that have had, are famous women in history. So the Amelia trial was almost 1,000 women with metastatic breast cancer previously had received exposure to a trastuzumab and taxane, and they went on to receive Q3 week trastuzumab emtansine versus lapatinib, which is another HER2-directed therapy, and capecitabine, which is a prodrug of 5-fluorouracil. And they found an improvement in progression-free survival of about 3 months and an overall survival improvement of about 6 months for the second-line therapy in HER2-positive metastatic breast cancer. It is given every 3 weeks. We give the first dose over 90 minutes to help reduce the rate of infusions. We were actually involved in the Amelia trial, and I only had one patient that required any type of pre-medication or any type of interaction, and we were one of the biggest sites in the study. Some unique adverse event profiles. So the hepatotoxicity, thrombocytopenia, and peripheral neuropathy are all due to the embtanzine, where our cardiotoxicity, embryofetal toxicity all comes from the trastuzumab. So HER2-directed therapies are known to be cardiotoxic. The risk is still very low, but in patients that have pre-existing cardiovascular risk, we just had a patient that had an MI, her EF went down to about 37%. We've been waiting for it to come back before we could potentially, and then a diagnosis of metastatic breast cancer afterwards, to see if we can use this medication. Ejection fraction monitoring is recommended for adatrastuzumab emtansine as well as pertuzumab, which is the next agent I'll talk about. The rates are very low. They're increased when patients have had exposure to anthracyclines, which is another class of chemotherapy commonly given to breast cancer patients. So pertuzumab, this is another one of my favorites, and I really like pertuzumab because of the profound effect that it has had on our patients. So this medication, say it's like a twin sister of trastuzumab, and that it binds to the extracellular domain of HER2, but instead of the homodimerization that occurs with trastuzumab, so trastuzumab prevents HER2 from binding to HER2 and the downstream signaling. Pertuzumab comes along and hangs out with trastuzumab on the HER2, but it's going to prevent the binding to HER1 and HER3. So you have a very complete HER blockade that occurs when you use the combination of pertuzumab and trastuzumab. It's pretty impressive. Honestly, when this study was going on, I didn't think it would have great outcomes. I said, we're already blocking HER2. Like, I don't think this is going to do a whole lot more for our patients. But the Cleopatra trial, which looked at patients first line, so very similar to what we looked at in adatrastuzumab emtansine, except this is first line therapy, took our standard taxane plus trastuzumab and added pertuzumab therapy. And we saw a progression-free survival improvement of about 6 months, but a 15-month improvement in the overall survival. So this is really unheard of in oncology, even in breast cancer. So our expectation for a metastatic HER2-positive patient is about 36 months. This study did show a little bit longer overall survival than what we would have expected, but to have a 50% improvement in the overall survival of what we expect for these patients in general, this is huge. So if the actual study overall survival hasn't come out yet, it's in publication, but there's been multiple press releases and kind of alerts to providers from the FDA saying this should be your standard of care first line for your metastatic HER2-positive breast cancer patients. We do provide a loading dose for pertuzumab, and then it's a maintenance of 420. It's flat dosing, so no mgs per kg, mgs per meter squared. It's a flat dosing every 3 weeks. One of the unique side effects that we see is diarrhea and rash, and this is because of that heterodimerization to HER1. HER1 is actually an EGFR, so endothelial growth factor. So we see a lot of alterations in patients' skin as well as their GI tract, primarily demonstrated with diarrhea. Very easily managed with Imodium. I don't know that, maybe a little bit of Lomotil, but vast majority of our patients are maintained very well on a little Imodium if they have this reaction. Same cardiotoxicity. These drugs were used in combination with trastuzumab, and they were quite concerned that we might see an increased rate of ejection fraction decline. There's been some mixed results basically saying that there's no statistically significant difference. In some studies it's been a little bit higher, in others it's been a little bit lower, but nothing that's statistically significantly different. There's no dose adjustments, it's flat dosing. But it is something important to point out that is only approved with the use of trastuzumab. It's basically having that cousin come along or a family member come along that's only given with trastuzumab. You won't give pertuzumab alone or as a single agent. So brentuximab I'm going to talk about very briefly, and the only reason I wanted to include it is because it is our second monoclonal antibody drug conjugate. It is also the only chimeric antibody that we're talking about today. So it has a pretty high rate of infusion-related reactions, partially because it is chimeric, so mouse-human split, and it affects our CD30 cells. So in Hodgkin's lymphoma, almost all of them express this CD30, and it is conjugated to a chemotherapy that I will refer to as MMAE. It is not approved on its own. Again, it was too toxic, and so they've bound it to brentuximab and been able to administer this chemotherapy as the brentuximab binds to our CD30 cells and internalizes it and releases this chemotherapy, also a microtubule inhibitor. So I'm not talking a lot about it today. I know Hodgkin's lymphoma is pretty rare, but it is unique in that it is a chimeric, and so we see a little bit more infusion-related reactions. Although we don't prophylax, but we do infuse it quite slowly for the first dose. It has been found that it's contraindicated with the combination of bleomycin, which is a chemotherapy. It's part of the first-line treatment for Hodgkin's lymphoma, and they saw almost a 40% rate of non-infectious pulmonary disease. And so it is not okay to give in that combination. I think we only have two more. So belimumab was the monoclonal antibody that we talked about at the beginning. So it's a human IgG1 monoclonal antibody that is directed at the immune system. And its target is BLyS. And BLyS is a B lymphocyte stimulator protein, and BLyS levels are found to be elevated in some patients with lupus. And it may play a role in their pathogenesis and promoting the formation of survival of memory B cells and plasmablast-making antibodies. So belimumab prevents the survival of these B lymphocytes by blocking the binding of soluble BLyS to receptors on the B lymphocytes. This results in the reduction of activity of B cell mediated immunity and the autoimmune response. Belimumab was approved based on BLyS 52 and BLyS 76, which took patients with a clinical diagnosis of lupus and gave them multiple doses of belimumab versus standard, in addition to standard of care, and compared it to placebo. And they found their primary endpoint was the basically the Systemic Lupus Response Index, or SRI, and they found improvements in those indexes, although they didn't see it at the 1 mg per kg dosing. So you'll see that the dosing that is recommended is 10 mg per kg, and is FDA for the treatment of adults with active lupus who are receiving standard therapy. They mirrored the 10 mg per kg every 2 weeks dosing, and it's fairly well tolerated. All the infusion reactions were a little bit higher, so 17% I wanted to point out, and nausea and diarrhea were really the two biggest side effects. They did see secondary malignancy or malignancies occurring in 6 of the patients out of 800 and some in the longer term trial. One unique outcome is that in their African American patient population, they really didn't see the response rates that they saw in the rest of the patient population. They're not sure why, but they kind of recommend against or using it with caution in our African American patients, so not giving a drug that may not have the best effect. So really assessing whether you're having a decrease in that score for your African American patient population. So to wrap up with denosumab, denosumab or Prolia is a fully human monoclonal antibody that targets rank L, which is receptor activator of nuclear factor kappa B gamma, or kappa B ligand. And this rank L is a member of the TNF superfamily of ligands and receptors that are essential for the function of bone-resorbing osteoclasts. So rank L and rank are both osteoclast precursors, are located on osteoclast precursors and on osteoclasts. And this interaction results in the activation, migration, and differentiation and fusion of hematopoietic cells in the osteoclast lineage. And this begins the process of resorbing the calcium from our bones. And so denosumab binds to this rank L, and therefore it inhibits osteoclast formation, and then in turn it decreases the bone resorption that occurs with osteoclasts. So we see an increase in bone mineral density and reduces the risk of fracture. The original trial with denosumab was called the Freedom Trial. It was a randomized controlled trial that looked at almost 8,000 postmenopausal women with significant osteoporosis, T-scores of -2.5 to -4, and they received denosumab every 6 months for 3 years. And they found an improvement in our bone mineral density. And the extension study, 6 years later, they still only received treatment for 3 years. They received also continued improvement in bone mineral density in the lumbar spine and hip. So it is used for osteoporosis in women and men at high risk for fracture. It is also used in breast cancer and prostate patients that are having either androgen deprivation or aromatase inhibitors on board. And it's given every 6 months. We do see, and I hear patients complain about musculoskeletal pain shortly after during the infusion. Long-term use is associated with ONJ and hypocalcemia. So whenever I see denosumab ordered, I'm always making sure that they're recommending calcium and vitamin D. It's very important for our patients to be on that. I did have a gentleman come in with a calcium of 4.8 after his first dose of denosumab, so it's very important. He did have underlying PKD, and so it's important too in your patients with underlying renal impairment to show that they're at increased risk for hypocalcemia. So in conclusion, I hope you've caught at least some of those mechanisms of actions of our monoclonal antibodies. It's a very complex pharmacology. It's a very exciting field. The mechanisms and pharmacology of these drugs are very cutting edge. And hopefully understand some of the common toxicities and unique toxicities of these agents, and can describe the mechanism of management for infusion-related reactions that we see. And hopefully, if you see patients and your patients having experience with some of these new monoclonal antibodies, hopefully you'll now know a little bit about them. So thank you very much for your attention and your time, and I would be happy to attempt to answer any questions that you may have.
So they have a reaction to the bleeding.
Yeah.
Is there different time frames of how long they last?
So generally with stopping the infusion, most of the reactions, once you start giving them treatment either with increased steroids or antihistamines, it will resolve. But sometimes, yeah, it's generally certain drugs, you see the reaction during the first 5 to 10 cc's, and it generally isn't something like that. It's generally later into the infusion, so 30 minutes to an hour is where I'm seeing the infusion-related reactions. But generally with stopping the infusion, giving some more steroids or antihistamines, we get fairly quick resolution if it's not a more severe anaphylaxis.
My lab director was on Remicade,
Oh, yeah.
and I think she had 2 or maybe 3 treatments.
Mm-hmm.
It went fine. The last one she got, if they increased the dosage or what,
Maybe.
but she had an immediate reaction to shut it off, and carrying on with the chest discomfort and the rash for the better part of 10 days.
Sometimes the rash or the more dermatologic effects can definitely last a lot longer. Sometimes too, it might have been a titration, or that might have been the time when they increased the rate. So we will, depending on the dosing scheme and how they do, titrate the rate with every dose or how they're doing. And so it could have been that they increased the rate to what we would call full rate with that dosing. Some of our patients can't tolerate it. I have a handful of patients with trastuzumab, which I think it's, the initial studies had a high rate of infusion-related reactions, things because of the drug that was given with. Post-marketing reports at 0.3%. But I have a patient that can't we generally infuse it over 30 minutes, and she's sitting at 2 hours for every one of her infusions. We increase the rate. She starts to have chest tightness and hypertension and kind of the runny eyes, watery nose, and everything like that. So I think it just stresses the importance of being near the bedside and being next to your patient as you're giving these drugs and giving that therapy, because it can occur. 20% of them occur after that second dose, and so just having that reaction that can occur really at any time. Did everyone learn something? Good. Good.
Don't give any drugs.